Thank you, and it's my pleasure to be with you again today. And my talk today is largely directed towards the family, but obviously, as we heard, that we're all in this together: physicians, families, therapists, all in how to make tuberous sclerosis something that is less feared and less devastating when families hear those words for the first time. I've been tasked, also I want to thank again for AIMS, partnering with the Tuberous Sclerosis Alliance of India to host this meeting. This is a very well-respected institution worldwide, well-known, and as you heard, in Cincinnati, we stole one of your best to come work with us, and we're very appreciative of what Dr. Arya is able to do for us in epilepsy. All right. I do want to be transparent in my relationships with many different organizations that provide me funding, either for me to support my family or, more importantly, for me to do many of the research activities that I do that are focused on tuberous sclerosis. So I've been asked to provide a timeline of where we are in tuberous sclerosis as a way to start our meeting today. Tuberous sclerosis is not a new disorder. We've known about it for centuries. The first descriptions of the skin findings were reported in 1835 in a dermatology skin atlas. And then the first tumors, which were described, was by Dr. von Recklinghausen, who is more famous for his contributions to neurofibromatosis. But he described tumors of the heart that we know now today are cardiac rhabdomyomas that occur in tuberous sclerosis. It was in 1879 where tuberous sclerosis first got its name. It was a French pathologist by the name of Dr. Bournonville who described tumors of the heart, of the brain and of the kidneys, and said that these were like tubers or roots. They were very firm and abnormal. And that's where we get the name of tuberous sclerosis. Our first set of diagnostic criteria in order to say somebody did or did not have tuberous sclerosis came in the early 1900s by Heinrich Vogt, who described the facial features of tuberous sclerosis combined with epilepsy that was difficult to treat and severe learning disabilities associated with tuberous sclerosis. And this was the status quo for our disease well until late 20th century, when Dr. Manuel Gomez, who is considered the father of modern tuberous sclerosis, provided us with much more detailed descriptions. And this was born out of his experience at the Mayo Clinic, where he had patients with tuberous sclerosis. He had the criteria from Vogt, and he said the criteria from Vogt is outdated and incorrect. And he recognized that tuberous sclerosis was much more broader and much more variable in how it affected individuals. It is a rare disease, but it's one of the more common rare diseases that we will find in the world. The birth incidence is estimated to be 1 in every 6,000. So that's more than a couple million people worldwide who are affected by tuberous sclerosis. In the United States, the estimated prevalence is somewhere between 50 and 70,000. And knowing how populous India is, there must be 2 to 3, 4 times that many individuals here in your country affected by tuberous sclerosis. The question is, where are they and how are they getting medical care? And that is one of the goals we have as the Tuberous Sclerosis Alliance, is to find them, help them, and in the end, help everyone with this rare disease. It's a genetic condition, meaning that mothers and fathers can pass it on to their children. However, most cases we find are where the children is the first person in the family to have the diagnosis. It also has what we call variable expression, meaning that tuberous sclerosis does not look the same in each individual. Each individual will have their own individual or personal version of tuberous sclerosis that affects them medically. It is a genetic disorder caused by DNA that each of us have and that we pass on to our children and that we receive from our parents. There are 2 genes that cause tuberous sclerosis. One is called TSC1 and the other is called TSC2. And a person with tuberous sclerosis has faulty DNA in one of these 2 genes. when we do genetic testing, we don't always identify those mutations. And we've done studies to look at why individuals do not have positive genetic testing, even though we know they have the diagnosis. And this is a study that we partnered with a few years ago, in which we looked at those patients who had negative genetic testing. And what we see here is that with traditional testing, about 85% of the patients we can find their mutation, but there were about 15% of patients that traditionally we could not diagnose with their DNA. When we looked at those, most of the mutations are in TSC2. They're much less frequent in TSC1. And we found that of those patients who failed to have positive testing, when we looked more deeply with new tests to look at DNA, we found that the majority of those patients were actually what we call mosaics. And you can't see my arrow, can you? Nope. So in number C is where we see where patients have mosaicism. Actually, I can do this. I think. No, all right. So mosaicism means that a person has the mutation, but only in specific parts of their body. And frequently that is the reason why we can't identify a DNA mutation. And in panel D here shows the various other types of mutations that aren't always picked up for traditional testing, with the two most common being what we call splice mutations and intronic deletions, which are not always sequenced with traditional methods. What we see here is a breakdown of the type of mutations that we analyzed in this particular study. And what you find here, many times when a patient has a genetic condition, we can find very specific parts of the gene that like to be mutated to cause that. We don't really see that in tuberous sclerosis. We see mutations in the entire length of the gene. And this is important for us because it affects our options, which I'll talk about at the very end, when we think about genetic treatments to correct for a disease. It's very helpful to us when everybody shares the same mutation. It means we have a harder process. It doesn't mean it's impossible, but it's a harder process for us to solve genetically. Genes matter because they are the recipe that make up our body. Genes are in the DNA, and DNA gets read by our body to form RNA, which is the message. And RNAs get turned into proteins, which is actually the workhorse. And when you put all the proteins together in a body, that's what forms us as individual people. But it all starts with the words on the page in the book of DNA that drive this process, even though it is a full process. And so I like to think about it as an example where DNA is a recipe book for cooking, and RNA is the individual recipes, which get turned into proteins, which are individual foods. But then when we put all those foods together in a feast is where we have a full person. So in tuberous sclerosis, this is what it looks like. It can affect any part of the body, and it does so in very specific ways that we recognize is how tuberous sclerosis is diagnosed. There are abnormalities in the brain and in the lungs and in the kidneys, in the heart, in the eye, and in the skin that are some of the primary manifestations of tuberous sclerosis. And some of these have different severities and different impacts on the person's overall life. We do break these down into what we call major criteria and minor criteria. Major criteria being if you have tuberous sclerosis and one of these things, it's usually tuberous sclerosis is the only cause for that finding. It is not absolute. There are exceptions to these rules, but tuberous sclerosis generally is the most common cause that we will find that lead to characteristic spots on the face, rough patches of skin called a shagreen patch, white spots or hypopigmented macules, little fibromas of the fingernails or the toenails, and also we can get lesions or spots in the eye called retinal hamartomas. In addition, when we do imaging scans with MRIs or with CAT scans or CT scans, we can find that there are ways that TSC affects the lungs called lymphangioliomyomatosis or LAM, renal angiomyolipomas, cardiac rhabdomyomas or heart tumors, kidney tumors, brain tubers which lead to epilepsy and learning difficulties, and brain tumors, which can cause other complications as well. In addition, there's many other things that happen in tuberous sclerosis, but they're common in other diseases as well. And so these are less helpful for us to make a diagnosis of tuberous sclerosis unless we are uncertain with the diagnosis, or that these occur and clinicians and families need not worry that something else has gone wrong, but it's actually tuberous sclerosis that's responsible. And these include little tiny white spots that occur on the skin called confetti lesions. This can be little areas of the teeth that are abnormal called dental pits. You can get fibromas of the gums. You can get white spots in the back of the eye. You can get cysts in the kidney. You can get polyps of the colon. You can get lesions in other tissues such as the liver or bones. And you can get lymphatic abnormalities as well. And so these are important for us to recognize, because sometimes I have found that there's been physicians that will see one of these minor manifestations and think that the patient has cancer and are recommending biopsies or cancer surgeries, when really if there's a recognition that they're associated with tuberous sclerosis, many times these things can be avoided. Several years ago, the Tuberous Sclerosis Alliance asked its members, what are you most worried about with regarding to you or your child's tuberous sclerosis? And not surprising, we see here, those that have the highest levels here are shown. Many of those have to do with brain manifestations, including epilepsy, that's very difficult to treat. TAND, which we will hear about later today, as well as skin and kidney lesions. And so we will have, through the course of today, many specialists that talk about these various aspects so that we can together learn and hopefully be more assured of what we can do, as well as what our plan is to move forward. We're able to make a diagnosed tuberous sclerosis in two different ways. One is by confirming the diagnosis just purely based on the exam and imaging findings in a patient with the diagnosis. And so these include several of the different skin findings that I talked about. It can be associated with various findings in the brain, in the lungs, or the kidneys that are helpful to us to make a diagnosis. Those are those major features. And then also several of those minor features. And what we do is we count them. And if a patient has two of the major features, or one major and two of the minor features, we know that that person has tuberous sclerosis. We can do genetic tests to confirm that, but we don't necessarily have to in every case. We already know, based on the clinical findings alone, that that patient has been correctly diagnosed. Sometimes, though, patients will not have so many of these features, and so if they only have one major or two minor features, we tell the family that we think it's possible you have tuberous sclerosis, but we're unable to confirm it based on your clinical findings alone. So what do we do in those cases? Well, one of the major things we can do is consult with a geneticist and can determine if it's possible to do DNA testing. And what we know is that a patient who has a positive mutation in one of these two known genes, and that mutation causes a disruption in protein function, that patient has tuberous sclerosis, even if they don't have all the clinical manifestations. One of the other things that's important for families and patients to understand, as well as we as doctors, is that not everything in TSC happens at the same time. There are certainly aspects of tuberous sclerosis that we see very, very early in life, even as early as a baby is being born, such as some of the heart abnormalities. Many of the neurological difficulties start very early in life, and then sometimes we can very early start to see some of the skin findings that make a diagnosis. Later on, it gets easier to do retinal examinations, and that we start to see kidney involvement. And then in adults, exclusively in adult women, we can see the lung abnormalities. So the caution we always tell the physicians is keep track of these patients that you're uncertain about their diagnosis, so that, because it may be later that more becomes available to confirm the diagnosis. We also tell the physicians to pay attention because if something hasn't happened yet, it's possible that that may happen down in the future, and it's important to explain that to families so that they're looking also and that we can get them the right care if that happens. From families, it makes tuberous sclerosis very difficult because it feels like you're always looking behind you of what else is coming in tuberous sclerosis that's going to make this child's life difficult. And we are working on that to make that a better situation. But until now, we do have to acknowledge that that concern is there. I told you we knew the two genes, and this is important for us and why genetic testing is helpful not only for diagnostic purposes, but sometimes it can give us an alert of the likelihood of other things to happen down the road. If somebody has a TSC2 versus a TSC1 mutation, this is a large study that was done years ago, and generally those patients with TSC2 mutations had a much harder course than those who had mutations in TSC1. The caveat or difficulty with making this statement is that it's no guarantee for each individual. Patients with TSC1 mutations can have a very difficult course in life because of their tuberous sclerosis, and there are patients with TSC2 mutations that get off very easy and have less manifestations. But in general, this helps clinicians particularly to be aware of the risk of other things happening. We see that this TSC1, TSC2 difference is also influential in how the brain functions, and that patients in general with TSC2 mutations will have a harder time learning and developing compared to those with TSC1. Now we're getting an era where we're starting to get significant numbers of patients who have had genetic testing combined with good clinicians who take careful notes on the different aspects of TSC that are occurring in them to start to find some very individual mutations that may have a, in this case, more mild life course. These are just 3 papers that have been published. There's been a few others since I made this slide that have shown that if there's a very specific mutation, that maybe that family only has heart manifestations and nothing else. And indeed, we've seen that in some of our families in Cincinnati as well. So this is a very exciting part to be a geneticist because this is what they live for. One thing is to make a diagnosis, but what they really want to do is know what the future holds because of that information. So rich in what it can tell us now that we're smart enough to start to do those type of analyses. Now when I talk about the landscape of tuberous sclerosis, we're going to talk a lot about what happens in this protein called mTOR. mTOR stands for mechanistic target of rapamycin, which is just a fancy name for a protein in our bodies whose job is to control whether a cell grows or doesn't grow. It has some other important roles as well, but that's fundamentally what its job to do. So if there's enough food in the body, this protein mTOR says grow, grow. If there are hormones in the body, this protein says grow. And when those hormones are absent or when there's not enough food, this protein says stop and wait. Okay? That's what its job is. And tuberous sclerosis is the main way that many of these signals get communicated to this protein mTOR. And so when you and I, who may not have tuberous sclerosis, we have TSC1 and TSC2, that their job is to limit mTOR's activity, particularly when there's a lack of food or lack of hormones. In a patient who has a diagnosis of tuberous sclerosis where one of these genes is missing in its function, no longer does mTOR have to listen to tuberous sclerosis genes. And as a result, mTOR allows things to grow even though the signal should be to tell them to stop. And that's why we get abnormalities in the brain or in the kidneys or the skin. Things grow when they shouldn't have because mTOR no longer has to be controlled. When we talk about what we're doing today in tuberous sclerosis is we use some medicines called mTOR inhibitors. And 2 of those that are most commonly used is one is called sirolimus and the second one is called everolimus. And what these are, instead of depending on TSC to do the brakes or to prevent mTOR from letting things grow, these medications stop mTOR from letting things grow. And so we have been using these for some time in tuberous sclerosis in patients who have the genetic mutations. These are the 2 drugs, and I get asked often by my patients, which is better? Is everolimus better than sirolimus? Is sirolimus better than everolimus? And the reality is, you see how similar they look? They're almost identical. And so we use both of them in our clinic based on which one is easiest for our patients to get. Now, sometimes they're easier, one is easier to get than the other because of how the FDA has approved them in the United States, but other times it's based on cost. And sirolimus in many instances is cheaper than everolimus, or there's generic versions of everolimus, and that's what we heard in Mumbai, that are much more economical than the expensive brand names. And we use generics in our clinic all the time as well, and so we're quite happy with either drug and whether they're brand or generic. I'm not going to go through all the different research studies that we've done at this point. I've given lectures in India before about these different studies, and many of your doctors have been to conferences where they've talked about these drugs as well. But suffice to say, we have approvals both in Europe and in the United States to treat brain tumors that occur in tuberous sclerosis with these drugs, renal tumors called renal angiomyolipomas. We also are able to treat lung cysts in women who have LAM, and we have refractory epilepsy. Patients who are not responding to other seizure treatments, we can use these mTOR inhibitors as another new way to treat epilepsy. We've also, as you heard, organized more than 70 international doctors from around the world who participated in evaluating all of the scientific studies that have been done up until 2012 and how to improve our ability to diagnose tuberous sclerosis, as well as the best ways for us to treat the different parts of the body that are affected. These have been published and they're available to everyone. You can find them on the internet. You can find them on the TS Alliance of India website. And you can always ask in WhatsApp, hey, where are those guidelines or those recommendations? And one of the other parents will be surely able to send those on to you almost immediately. So where are we now? What are we working on? Well, some of the key things that that are in our immediate future to work on and solve is we continue to work on the effectiveness of the surveillance guidelines and to create better evidence so we know exactly who might need MRIs and when treatments might be best started for various aspects of TSC, and to improve our support. And you'll hear more about that, particularly in the area of TAND, here from Dr. Gibson. We also are working on strategies that we can predict epilepsy in tuberous sclerosis and prevent it if possible. I'm not going to talk about today, but we have a project that's ongoing that we're trying to improve epilepsy surgery outcomes in tuberous sclerosis. Many of our patients will not respond to traditional seizure drugs, and epilepsy surgery remains a very important option for us in patients who don't respond to medication. We're also exploring the use of laser instead of traditional surgeries as a way to minimize the complications that might come from epilepsy surgery itself. We're also working on better ways to diagnose and treat autism in TSC. We know it has a very high prevalence. We know many of our patients need services that they have difficulty accessing, and so a lot of our work around TAND is not entirely, but has a major component, this aspect of improving diagnosis earlier and treating effectively, whether that be with medications or with other treatments. And then the last one is even though we have evidence how these mTOR inhibitors work in tuberous sclerosis, we continue to try to improve those. How long does a patient need to be treated with these medications? Currently, the expectation is it's going to be lifelong because the genetics that drive tuberous sclerosis don't go away, and we need a way to correct for that. But maybe we can improve the dosing. Maybe we have new generations of medications that can work as mTOR inhibitors that are even better than the ones we have today. Also, maybe there's other aspects of TSC that we can use for treating mTOR with mTOR inhibitors than the ones we already have approved. So one of the examples on how we're working to predict epilepsy is using EEGs or brainwave studies that we have that patients with tuberous sclerosis and epilepsy have done regularly. We enroll babies in a study before they ever had a seizure, and we asked if we do EEGs at like every month and a half or so, every 6 weeks, how good is that EEG at telling us about that child's risk for epilepsy? And so we had 32 subjects that were able to complete this portion of the study, of which about 2/3 of them had seizures and 1/3 did not. What we found was that in almost all of them, about 85% of the patients, the EEG told us ahead of time that that patient was getting ready to start having seizures. And most of the time when patients had a normal EEG, they were not going to have seizures in the near future. And so what you see here is a PPV, which means positive predictive value, and NPV means a negative predictive value. And without going into how these are calculated, it means that about 77% of patients who are going to have seizures, we can know that before that just by looking at their EEGs. And then we also know that patients who are not going to have epilepsy, about 70% of them, we can use the EEG to reassure parents that it's unlikely, not 100% sure, but it's unlikely that they're going to have seizures in the near future. We also found out how long it took for the EEG to tell us that something was amiss. And on average, it was about 3 months. That within about 3 months, we could, in general, know that a patient was getting ready to have seizures. Now, some patients would have seizures within a week, and other patients may take 4 or 5 months before they would have seizures. But the average was about 3 months. This is really important to us as clinicians because it tells us we have a chance that in many patients, roughly about 3 months ahead of time, we have the opportunity to start teaching the families about seizures, what they're going to look like, what to tell us about, and more importantly, maybe we can start treatment either immediate or before they start to have seizures. The last thing is, and this is pretty important for resident doctors and students to know, historically, when we talk about epilepsy and tuberous sclerosis, we taught doctors in training to look for infantile spasms, which is a very specific type of seizure where the children will convulse and then they'll relax, and then a few seconds later they'll convulse again and then they'll relax. It's not the one you see in the movies where people do this, but they'll just do one and then they'll stop. And we taught all our medical students and our residents to look for this, and if you see it, you do have to worry about tuberous sclerosis first before you think of anything else. However, what we find is that many of these patients also have what we call partial seizures, and this was part of my education that I did not get when I was in medical school. That I knew what partial seizures were, but I wasn't taught to be looking for those in infants with tuberous sclerosis. And roughly about half of the infants will have partial seizures before or at the same time they start having spasms. So this is important to teach families. And the partial seizures may be very subtle. It may be just a rhythmic jerk of this, or it may be a hand twitch. It may be a little jerk of the eyes, a blink of the eyes, or eyes may get stuck. Or frequently what we're seeing is what we call negative symptoms of epilepsy. Meaning the child is playing, is smiling, and they kind of freeze, and they stop interacting. And the parents think, that was very odd. You know, I was just playing, or I was just feeding my baby, and they just stopped. So we teach them about that. That's another way that the partial seizures may look like in this very young age. What's important is that the EEG that normally is associated with infantile spasms, which is called hypsarrhythmia, that we can't wait for that. If we wait for that, the process of epilepsy has already well begun. And we know that if we recognize these more subtle seizures very early on, we can prevent these abnormal EEGs that are so worrisome to us long term. What we know is the earlier we recognize a child's having seizures, and we can start treatment, and the recommended treatment is a drug called vigabatrin, that we can improve significantly the likelihood that that patient will go on to have controllable epilepsy, and they will go on to have much less severe developmental difficulties. And so this has been the mantra of what we've done now, and with our new recommendations that will come out this year, it will be recommended that every baby who's been diagnosed with tuberous sclerosis, even if they've never had a seizure, that they have these frequent EEGs to make sure that both the doctor and the family are ready to start treatment, maybe even start treatment before the seizures happen. I'm going to skip this, these next two slides, so just for consistency. This has to do with dosing, and this is more for the doctors. that it's important not to dose too low and too short in these families because patients have a significant risk of recurrence if the doctors are too timid and nervous about using this medication. This is why we're excited about this. There was a study by Dr. Sergiusz Józwiak in Poland who looked at patients who started treatment after they started having seizures versus patients that they started treatment when the EEG told them that seizures were coming. And what you see here in the first is how many patients were seizure-free by the time they were 24 months of age. And what we see is that with traditional treatment, the rate of patients that were seizure-free was only 35%. However, in the patients that started treatment before, when the EEG told them that seizures were coming, the rate of patients who were still having seizures at 24 months was only 7%. So that was a significant change. And likewise, we see the number of patients with severe intellectual disability at 24 months was reduced significantly in those patients who got early treatment. So now there's two studies that are ongoing. One is called EPISTOP, which is being led by Dr. Józwiak, and then the PREVENT study, which is done by our research consortium in the United States, each of which is enrolling babies, monitoring their EEGs, and initiating treatment when the EEG shows abnormalities concerning the seizures. EPISTOP has finished its enrollment and completed its studies, but we have yet to get detailed results from that study, so we're looking forward to what they have found in that research. The United States study is finishing enrollment this month, and so we would expect to have results in the next couple of years that confirm and expand on those results from the EPISTOP study. What I want to spend some other time talking about, because we don't have dermatology later in our program today, is some of these skin manifestations and what we're doing for those. And this is an example of how we're looking to expand mTOR inhibitors beyond what we already have approved today. With the big one being the facial antifibromas. When we did the constituent survey with families, this was one of the most common things that people were worried about was these facial lesions. Traditionally, we treat these with laser. You could go to a dermatology or to a plastic surgeon who has the lasers available, and you can essentially burn the different lesions off using the pinpoint accuracy that lasers provide. And you can see an example here of a man with significant angiofibromas who underwent that laser treatment with very positive results. There are some negative downsides to this treatment. Number one is it hurts. For a couple days afterward, the patient will look like they had a very bad burn where everything is scabbed over. That's temporary, but it's not fun. And the second thing is that it's not a permanent fix. Patients will need to repeat this as early as 6 months later. But some patients, traditionally, most of our patients can go between 3 and 5 years before they need to do it again. But it is temporary. It doesn't fully solve angiofibromas completely. So what we've done is partner with our colleagues down in Texas who run a tuberous sclerosis clinic there. And they tested these mTOR inhibitors put into a cream that can be put on the face as a way to be treatment. And what you see here on the top are patients before they got treatment, and on the bottom, what that looked like after treatment. And there was a significant improvement. 80% of patients reported improvement as long as they continued on the medicine. Now, we don't have a way to get this commercially yet. There's no prescription version that you can go to a pharmacy and pick up. But those studies are underway now. And so we hope within the next few years that we have official versions that you and I can buy or give prescriptions to our patients so that they can go pick up a cream for this. This has been pretty important for many teenagers with their self-esteem and how they interact with other individuals as well as adults. So I talked about this as well. I talked about how we have the genes that were discovered. I've talked about how we use the mTOR inhibitor pathway and drugs that can treat that. And so now, since 2006 is when we started doing the first treatment studies using mTOR inhibitors to treat brain tumors. And then lastly, we have all these approved indications now for the treatment. But what do we still have left to do? Well, we still are not as good as we would like. I told you that TSC2 versus TSC1 can help us maybe make some generalized statements about a patient's disease risk, but we haven't got that down to the individual level, except for these very few mutations that we've described already. So we're looking at using either imaging findings and particularly genetics so that when you come in to consult with myself as a TSC clinician or with a genetics specialist, that we can provide better and better answers to you about when and what might go wrong in the future for your specific child. We're also starting to try to move away from treatments that just treat very specific parts of TSC to maybe treatments that can change the entire life's course of a person with tuberous sclerosis. Like I said, we already have SAGA treatments with medications, and we can use surgery also for these brain tumors. But we're exploring how to better use those medications, and maybe earlier treatment can be preventative. Same thing with epilepsy, using not just mTOR inhibitors, but also other seizure medications and treatments, and also better treatments for epilepsy surgery, how to identify where the seizures are coming from, and better surgeries that can actually get rid of that focus without causing long-term disability. We are looking at medications to better treat autism and its associated behaviors, but particularly we're looking at things that don't involve medicine, that can be just as effective, if not better effective than medications, to treat many of the difficult behaviors that we encounter in children with tuberous sclerosis who also have autism. We're looking at ways of preventing kidney disease and kidney tumors from even arising, and making it so that kidneys are no longer a concern for anybody who receives this diagnosis. And the same thing with the lung disease that occurs in women. Ultimately, our goal is to come up with genetic therapies for tuberous sclerosis. There already are other rare diseases for which genetic treatments are available. And tuberous sclerosis, because of how the genes work in tuberous sclerosis, that's going to be harder for us than some of these other diseases. But it's something that we should shoot for, and it's something that people are starting to work on, some of those challenges that are unique to tuberous sclerosis when we think about the potential for possibly genetic therapies in the future. So in summary, TSC definitely can affect any part of the body. Predicting when and where and how severe TSC is our next challenge, and that's what we're working on as a group that are dedicated to making this disease better. We have made significant advances in tuberous sclerosis, particularly with the use of mTOR inhibitors, but we know that there's still more we can do. How to use these mTOR inhibitors better, and particularly maybe how to use them in preventative fashion rather than waiting until things go wrong before we start treatment. And we've started with epilepsy. Epilepsy we view as just the first of what we hope many ways that we can move from a reaction type mindset to a prevention type mindset for all aspects of TSC. I want to thank many of the individuals that have been working on these projects with me over the years. We have the Clinical Research Consortium that spans across the entire United States. We have many different research foundations that have provided us funding to do these studies, and many important and very smart people that help to design these studies and help us understand the results of them. I also would be amiss if I didn't thank our partnership with the many people in our tuberous sclerosis clinic in Cincinnati that help us coordinate all this care. We heard from Dr. Ashok this morning how important it is to bring all these specialties together. This did not happen overnight in Cincinnati. We started 25 years ago, and we started with just 2 or 3 clinicians at different specialties that were willing to work together. And it started with a geneticist, it started with a neurologist and a nephrologist. And then little by little, we brought in other specialties as they saw what we were doing was pretty darn exciting. So that's what I would recommend. If and when we can start a TSC clinic here in Ames and Delhi, start with a few passionate folks who can get the ball rolling, and then you will find others will join you along the way. And so thank you very much.
Thank you, Dr. Krueger, for a very interesting talk. And what measures we can take to prevent it?
So what generally is progressive, or most progressive in children, are the brain findings, where epilepsy frequently will occur in almost everybody before they turn 1 year of age. So that usually is why many of these patients are patients of child neurologists, because the epilepsy is so prominent. We focus on that first and foremost. We also focus on the heart, even though for many the heart issues will go away, and we're very thankful for that. But the epilepsy ones won't. The epilepsy ones typically progress and become worse. And then we also see development, learning to talk and learning to walk and other things becoming difficult in a patient whose epilepsy we were not able to control. So that's first and foremost on our list that we go after in everybody who's a child. We also pay attention to the skin findings that show up more when in the preschool years, and are ready to develop and work with those. And then the kidney abnormalities come later in childhood, so we have to look for all of those things. But it's the epilepsy that is number one on the list. Okay. What we can do to prevent those? Well, right now, we're working on that. From a parent standpoint, the single most thing that can be done is to find a TSC doctor. Usually it's going to either be a geneticist or a child neurologist that can help them with this journey, because they are the ones that know when you need to see one of these other specialists, and they're the ones that are paying attention to these studies that we're doing right now that will indicate who needs treatment early on in life to prevent later aspects. So stay tuned. I don't have all the answers. As far as specific diets or specific natural remedies that you might buy from somebody on the street, there's nothing in those that tell us how to prevent things. It's all built around what we're trying to do around epilepsy at the moment.
There are some families here who might not understand English very well. तो किसको अगर कुछ पूछना है तो आप हिंदी में पूछ सकते हैं और मैं ट्रांसलेट करके बताऊंगी डॉक्टर क्रूगर को आंसर के लिए। थोड़ा सा समरी बताती हूँ जो बताया गया है इसमें। ट्यूबरस स्क्लेरोसिस की बीमारी रेयर बीमारी है, उतना कॉमन बीमारी नहीं है, पर जो न्यूरोलॉजी वाले डॉक्टर हैं, जेनेटिक्स वाले डॉक्टर हैं, उनके पास काफ़ी बच्चे इस बीमारी से आते हैं और उसकी जो प्रॉब्लम्स होती हैं तो ब्रेन से रिलेटेड प्रॉब्लम्स होती हैं जिसकी वजह से बच्चे को दौरे आ सकते हैं और साथ में बच्चा थोड़ा विकास में पीछे हो सकता है या बच्चे के बिहेवियर में कुछ प्रॉब्लम्स हो सकती हैं। इसके अलावा स्किन की प्रॉब्लम्स होती हैं, कुछ आपके किसी बच्चे में होगा कि स्किन में फेस पे कुछ लीजन हो या बॉडी में हम पूरा जब बच्चे को देखते हैं तो आपसे बोलते हैं कि कोई निशान तो नहीं है वो देखने के लिए, और आगे जाके बच्चे की किडनी में भी प्रॉब्लम्स आ सकते हैं। तो इस सबको उसकी समरी बताई है और ये बताया है कि दौरे कंट्रोल करने के लिए हमें बच्चे को मॉनिटर करना पड़ता है और उसको दौरों को अच्छा कंट्रोल करने के लिए जल्दी ट्रीटमेंट जरूरी है और उसके लिए स्पेसिफिक दवाइयाँ हैं, जिनमें से कुछ दवाइयाँ यहाँ इंडिया में नहीं मिलती हैं। और अगर बच्चे को कोई मेजर समस्या नहीं भी है, मान लीजिए दौरे नहीं भी हैं, तो भी 1 से 3 साल में बच्चे को दिखाते रहना है अपने डॉक्टर को, क्योंकि पीरियोडिक मॉनिटरिंग जरूरी है। तो इस सब के बेसिस में आपके बच्चे के विषय में कोई स्पेसिफिक क्वेश्चन अगर है तो आप बताएं, मैं ट्रांसलेट करूँगी आंसर के। कितना बड़ा है आपका?
10 ईयर है। 2.5 साल से स्टार्ट हुआ था। दवाई से स्टार्ट हुई थी, फिर 1 साल में सिंपल हो गई थी। अभी थोड़े अभी उससे देखते दाने से स्टार्ट हुए, जैसे फिर इंडिया में कहते हैं मक्के या इस टाइप में स्टार्ट हो गए तो बारीक पर मैंने इसको कहीं दिखाया नहीं, तो उसके बाद में
So what he's saying is he has a 10-year-old boy with tuberous sclerosis, diagnosed around 2.5 years of age and had seizures at that point in time. Started on some therapy and the seizures are controlled now. और दवाई अभी आपने बंद कर दी है। So now we have started developing some skin lesions. So he wants to know whether it's a part of the disease or something else, and does he need to take consultation?
So yes, the skin lesions are part of tuberous sclerosis for sure, and if they are bothersome to the child or the parents, then yes, seeing a skin specialist could be very helpful to explore whether or not the treatments, whether they be topical treatments or whether there be other treatments for them need to be done. Not every patient with skin findings need to be treated.
तो ये कह रहे हैं कि स्किन वाले डॉक्टर को दिखाना चाहिए, और एक बात ये भी है कि आप जैसे एम्स में भी फॉलो कर रहे हैं, अगर दौरे अभी नहीं भी हैं तो भी मैं सजेस्ट करूँगी कि आप फॉलोअप में आइए, क्योंकि हमको दूसरी चीज़ें भी इवैल्यूएट करनी होती हैं। तो यहाँ पर दिखाने के बाद हम देखने के बाद स्किन में आपको रेफर कर सकते हैं अगर जरूरत पड़े। और
ये स्किन के ये बढ़ते जा रहे हैं, ये
कितना बड़ा बच्चा है आपका?
मैंने ये 21 साल का हो रहा है।
21 साल का बच्चा है।
2 बच्चे हैं मेरे, दोनों को सेम प्रॉब्लम है। हाँ जी।
और दोनों की समस्या ये है कि
दोनों की
समस्या बढ़ रहे हैं।
हाँ जी।
So 2 affected boys with TS, one is 21 years old. दोनों आए हैं?
हाँ जी, दोनों आए हैं।
दौरे वगैरह नहीं आते हैं किसी को?
नहीं मैडम, अभी तो फिलहाल दौरे नहीं आ रहे हैं। एक की दवाई बंद हो चुकी है, वो उसकी साइकोटिक्स की चल रही है, दौरे की बंद कर दी है उन्होंने। और एक
So the same answer to this father here. We're working on a prescription version of treatments, but until then, consultation with a dermatologist can explore what laser treatments or other therapies might be done, and whether your children need those. Again, they sometimes can hurt, they sometimes can bleed. Most importantly, we treat them because they bother the individual and how other people look at them. And all of those things can be explored with a dermatology expert.
उन्होंने बताया कि स्किन वाले डॉक्टर को दिखाना चाहिए, और जैसा आपने देखा होगा लेक्चर में, लेजर ट्रीटमेंट से अगर बहुत ज़्यादा हो तो लेजर ट्रीटमेंट किया जाता है, पर उसके अपने भी साइड इफेक्ट्स होते हैं। और अभी ये बता रहे हैं कि क्रीम के बारे में रिसर्च हो रही है जो शायद कुछ समय बाद अवेलेबल हो जाएगी, जिसके लोकल एप्लीकेशन से फ़ायदा होगा। तो अगर वो बहुत बॉदरसम है, बड़े दिखते हैं, प्रॉब्लम है, तो स्किन वाले डॉक्टर को दिखाना चाहिए कि लेजर ट्रीटमेंट से।
मैम लेजर भी करा है लेकिन फिर वापस
हो गए। हाँ, तो ये भी बताया था कि लेजर ट्रीटमेंट के बाद भी दोबारा हो जाते हैं, 6 महीने में भी हो जाते हैं, 3 साल 5 साल में भी हो जाते हैं, क्योंकि बीमारी तो कंट्रोल नहीं हो रही है ना, वो तो जेनेटिक बीमारी है। वो वापस आएंगे, पर अगर ज्यादा परेशान कर रहे हैं और बहुत डिस्फिगरमेंट है तो इसी से लेजर ट्रीटमेंट वाज डन बट दे केम बैक।
Yeah, and earlier I mentioned that is the one thing we wish that wasn't the case, but they do come back, and you have to do it again.
मैम, हमारे तीन लड़के हैं, एक लड़का सबसे बड़ा है, ये 2 छोटे हैं, उसको कोई प्रॉब्लम नहीं है, और हमारे कोई जेनेटिक प्रॉब्लम नहीं है पूरे खानदान में। ये प्रॉब्लम ये जो राजीव है, इसको 1.25 महीने में आई थी, आज 21 साल का हो गया है। अब इसकी कम से कम 2-3 साल हो गए जो दौरे की दवाई बंद करी हुई है, और वो भी 1.25 महीने के था, तब से उसका इलाज चला। 18 साल का हो गया फरवरी में। तो ये इनकी स्किन की है, तो स्किन वाले डॉक्टर बोलते हैं कि ये पिंपल्स आएंगे नहीं, लेजर से भी करवाया है और वैसे भी करवाया है कि ये दोबारा आ जाएंगे। और अब साइटिक केस बोलते हैं कि जैसे हम कंफ्यूज रहते हैं कि जी ये दौरे नहीं है, तो हमें एक तरह की खुशी होती है, और फिर एक जो 18 साल इन्होंने दवाई खाई है, तो वो दौरे हमने देखे हैं, लेकिन इतने भी नहीं देखे। बचपन में ज्यादा पड़ते थे, लेकिन जैसे जैसे बड़े हो गए वैसे वैसे इनके दौरे भी कम हो गए। अब दवाइयाँ इनकी बंद है।
अभी आप कहाँ दिखा रहे हैं?
जी अभी तो हम जनकपुरी दिखवा रहे हैं। हाँ जी, वहाँ रेफर कर दिए।
तो जैसे आपको बताया था कि रेगुलर फॉलोअप जरूरी है बाद में भी, तो चाहे कोई सिम्टम हो या नहीं हो, 1 साल में एक बार आपको अपने न्यूरो वाले डॉक्टर को दिखाना चाहिए। और जैसे आपने बोला कि परिवार में किसी को नहीं है पर 2 बच्चों को बीमारी है, आप लोगों का टेस्ट जेनेटिक टेस्ट हुआ है फैमिली में पूरा?
जी मुझे भी देखा गया था, इनका कलावती में पहले इलाज चला था, अब ये बड़े हो गए तो
हम डिस्कस कर सकते हैं बाद में। पर परिवार में नहीं होने के बाद भी बच्चों में ये बीमारी आ सकती है, उसके बारे में हम डिस्कस करें। She was asking with no family history but 2 boys are affected. So what is the reason?
You're going to be a better expert than I am. Okay, good. This is where a geneticist is better at it than I am. I recognize that I have colleagues that get advanced training on how to explain that.
आपकी रिपोर्ट्स देख लेंगे उसके बाद
मैं ये पूछना था, मेरा बेटा है 7.5 ईयर का हो गया है, सीजर उसके अभी तक कंट्रोल है नहीं, और मेरे को लगता है कि अभी वो बढ़ते ही जा रहे हैं, पहले से ज्यादा होते जा रहे हैं, और आजकल क्या करता है 2-2, 3-3 दिन तक खाना नहीं खाता है।
इसकी एक स्पेसिफिक दवाई होती है सैंपल, जो आजकल बड़ी मुश्किल से मिलती है।
मैम वो भी कई बार चालू हो चुकी है,
अच्छी डोज में ट्रायल है, उसकी डोज कई दफा हम पूरी मात्रा में नहीं देते। और अब किस प्रकार के दौरे, अभी झटके ही हैं या लंबे?
नहीं, पूरा शरीर अकड़ जाता है उसका, ऐसे ऐसे होके मतलब आधा मिनट के करीब आते हैं, फिर ठीक हो जाता है।
तो कितनी डोज तक दी है, क्या क्या दवाइयाँ दी है? इसमें दौरे कई बच्चों में कंट्रोल करने बहुत मुश्किल होते हैं, ये आप ठीक कह रहे हैं।
2-3 बार स्टार्ट कर चुके हैं,
फिर 6 महीने से ज्यादा नहीं देते ना, वो बंद कर दिया। 2-3 बार शुरू हुई है, बंद हो चुकी है, अब नहीं चल रही, फिलहाल नहीं है।
हाँ, तो यही बात है कि वो बीच बीच में जब बंद भी होती है, उसके देते हुए कंट्रोल के चांस बेहतर है दूसरी दवाइयों से, लेकिन उसकी डोज जो आम तौर पे यूज की जाती है वो बहुत हल्की होती है, आपको बहुत अच्छी डोज में देनी पड़ेगी। प्रॉब्लम ये है इसकी कॉस्ट भी बहुत होती है।
हाँ जी,
बहुत कॉस्ट है। ये आज ग्रे मार्केट में मिलती है, जो पहले पत्ता 500 रुपए का मिलता था, आज 1100 रुपए पर स्ट्रिप का मिल रहा है, जो अफोर्ड करना आसान नहीं है। और उसकी डोज भी अब हम जानते हैं कि जो हम पहले यूज करते थे उससे 3 गुना तक डोज हो सकती है इसकी इस्तेमाल के लिए। और दूसरा जो आप कहते हैं कि ज्यादा देर तक नहीं यूज कर सकते, उसके लिए आप तोड़ हैं कि आप सैवरिन लॉन्ग टर्म पे यूज करें, दवाइयां दें जिससे कि नजर पे असर ना हो। तो वो रीजन नहीं है कि हम नहीं यूज कर सकते, ये बात नहीं है, लेकिन उसके साथ और दवाइयां देनी पड़ती है ताकि नजर पे ना असर पड़े।
और आपको फिर दिखाना चाहिए रात में, ये इम्पोर्टेंट बात है, जहाँ भी आप दिखा रहे हैं दिखा रहे हैं आप फिर फॉलो करना चाहिए। So what she asked was uncontrolled seizures and intermittent use of Sabril. Ma'am explained that it has to be used continuously and can be used for a long time.
Yes, very good. Thank you.